Okay, people, hello. Do you hear me clearly? I hope you're doing well too. So, people, I see chat is live. A lot of people already wrote their name, but what I really need, I just want your direct involvement and participation into the lecture. Because basically, after the analyzing of your watching of these lectures, we are becoming discouraging indeed, because your medium like mean of your time watching, the average time is estimated approximately 8 or 9 minutes. Yeah, for sure, you can watch it later. You can do that like in a separate way, 10 after 10 minutes. But anyway, normally lecture is like 1 hour and 1.5 hours when you can watch, digest information and ask. And it's quite easy to do that online. So you just can use the chat for asking the question. So that's why I gave this first slide for you to make some kind of joke about this, about what you are actually ask and what you would like to ask during the lecture. So I just want to know exactly if you are interested in these lectures or not. So for that reason, from this moment, from this lecture, as you may find it on our website, I propose to use the Google form for registration. And this Google form is not only about to write your name, your group, or your decade, but that's also about the how can you catch some information from the lecture. So I put 4 questions in this Google form, and this question is actually about some very small piece of information from 4 points of time of this lecture. So if you are watching this lecture, you can answer these questions. Don't worry about absence or not. So that's just to check out how you're really interested in the lectures and how you can really keep your attention on this video material. However, that's not the point of our discussion today, and as you may remember, we are on the route of pathology, and our next stop logically is on the very positive moment. That's a topic dedicated to repair and cell renewal. So in fact, just what I want to know now, that's about the feedback. So could you please write some information if you can really hear me? Just write it in the chat if it's true. Could you please make me a favor to write if everything is okay with the feedback? So far, no response. Okay, thank you, Rashid. So hereby I want to continue, and today we're discussing about the cell renewal and repair. Cell renewal and repair, they are combined under the same topic because that's about the restoration of the cell population, but the causes of this restoration are different because cell renewal or regeneration occurs continuously in the so-called labile tissues. We will discuss about that. What is exactly the labile tissues? For example, the bone marrow, different types of epithelium, like epidermis, mucosal epithelium. And basically this type of process, regeneration or cell renewal, is driven by colony stimulating factors. In contrast to that, repair, which sometimes we call healing, that's the restoration of tissue architecture and function after an injury. And you see, we apply the repair basically for parenchymal and connective tissues. However, that's a more common term. Meanwhile, the healing, that's the term which we apply for specifically the surface epithelia, like wound healing. Anyway, repair, healing, or whatever, occurs by two types of reaction. That's the regeneration by proliferation of residual uninjured cells in stable tissues, and maturation of tissue stem cells in labile tissues. And we call this type of repair restitution, which means complete repair. In contrast, in some organs and tissues, and that's the most common type of repair, we observe the deposition of connective tissue to form a scar. That's the substitution. Substitution by fibrous tissue. As the particular form of substitution, we know the process of fibrosis. We will discuss about that later. Why this topic is important? So if you want to become a surgeon, you have to realize how it works, how the healing of damaged of injured tissues, especially after the surgical intervention, is restoring, driven by our genetically determined forces. And as you may see from this schematic, that's very, very complicated process. That's over-regulated. You see how many participants, you see how many compartments, how many cells are involved into this process. So here you can just see the 13 steps of this, starting from inflammation, because yes, inflammation is just the beginning, in fact, of the tissue repair. And we already discussed about that, and the chronic inflammation, and during the chronic inflammation we already see the attempts of tissue to restore itself. So to figure out how this over-regulated process is going on, so that's the purpose and goal of our current lecture. And yes, we will use a lot of abbreviations just to demonstrate you how many they are. I just want to propose you something like this, like colony stimulative factors. We will do CSF. We will discuss about growth factors, GFs, like VGF, and their receptors, VEGFR, for example. Tumor necrosis factor, as you may know, it was already mentioned in the topic of chronic inflammation. Extracellular matrix, that's well known, macrophage, fibroblast, endothelial cell, and others. They are participating in the current lecture. The outline of our lecture is embracing such wide spectrum of the problems, starting from tissue growth and renewal. That's important because it's explaining how the repair is regulating that's overlapping processes. We will start from intercellular communication and how the growth factors may act. I would like to compare reparative capacities of different animal species, because you know that jellyfish, for example, that's their almost perfect organism from the point of view of regenerative capacity. We will discuss about the repair and healing as basics, and we will discuss about the specific regeneration and repair in the certain organs and tissues. And after all, I want to briefly familiarize you with the regenerative medicine and its frontier. Tissue growth and control of cell population, that's basically the regulation of the baseline cell population. Baseline cell population, that's entire population of all the cells in our organism. Starting from the embryonal period and the post-birth period, we have dealt with different types of tissues. Their differentiation, their growth, basically regulating by two opposite processes. That's the proliferation and apoptosis. Also, we should know about the certain population of so-called stem cells. That's the pluripotent cells, which could be differentiated in embryonic or post-embryonic period, doesn't matter, in any type of tissues. It depends on the stem cells. Tissue growth and cell population control. The types of tissue growth, that's deflecting exactly what we discussed on the first lecture about the adaptive processes. As you remember, there are four types of the adaptation: hyperplasia, hypertrophy, metaplasia, and atrophy. And in terms of hyperplasia and hypertrophy, we have to mention these two types of tissue growth: multiplicative, that involving an increase in numbers of cell or nuclei, as you wish, associated with cytoplasm and syncytia, by mitotic cell divisions. This type of growth occurs in all tissues during embryogenesis. Another type of tissue growth, that's auxetic. Auxetic type of tissue growth resulting from increased size of individual cells, seen in growing skeletal muscle or in the myocardium. So it's responsible, this type of growth is responsible for the hypertrophy. Accretionary growth, that's the increase of intercellular tissue components, as in bone and cartilage. And sometimes we consider visual enlargement of the organ, but in fact that's the false hypertrophy, because instead of the functional cells we see the growth of the extracellular matrix. And combined patterns, in fact that's the most common type of cell tissue growth. The very important point in understanding of the tissue renewal and repair, that's the cell matrix communication. You know that our cells, they are not just suspended in vacuum. They are interacting with an extracellular matrix. And if you want this kind of comparison, our cells, it's like spiders, and the extracellular matrix, it's like a spider web. And our cells, they just like fill in the mechanical distortions of the space due to the some vibrations of extracellular matrix. And these mechanical receptors, as you may see in the on this image, they are associated with so-called integrin receptors. These integrin receptors in their turn connected to the laminin fibers and fibronectin components of extracellular matrix, and after that they are connected to the collagen matrix. That's from one side, and from another side the submembrane domain of the integrin receptor, that's the focal adhesion complexes, connected to the cytoskeleton of the cell. So in such a way you can imagine that the mechanical distortion of the extracellular matrix finally could be reflected in the disturbances in the nucleus. So That's one mechanism of interaction. Another mechanism is associated with the humoral regulation of cell growth and proliferation, and they are connected with the intercellular communications. And that's important point of the lecture, because that's the first question in the Google form for registration of this lecture. So now, if you didn't do that before, you can open up the link on our website to this Google form, and you can try to answer this first question. That's about the intercellular communications. There are basically three types of intercellular communications. There's autocrine signaling, then cell is stimulating itself. Paracrine signaling, that's the interactions between the neighbor cells, and endocrine signaling, that's the interactions on distance. And there are specific population of the endocrine cells, like pancreatic islet cells, parathyroid glands, pituitary glands, etc. And they distribute the hormones or other active products all over their body. So to the endocrine organ, we can include the liver, because liver produces a lot of growth factors, and they are acting on the systemic level. That's why that's also the endocrine type of signaling and endocrine type of intercellular communications. And after all, these interactions by the hormonal factors, by growth factors and colony stimulating factors, are targeted to the specific receptors on the surface or in the nucleus of different cell populations. Basically, we can describe like several types of signal transduction pathways. They are playing different roles, but in the healing and repair. But basically, they are all involved into the process of tissue repair and healing. See, there are very bizarre names like fizzled receptor for VNT, hedgehog, Sonic Hedgehog. If you remember the computer game, video game from 19th, if you're old enough to remember that. There are integrin receptor, extracellular matrix interaction, what I already discussed with you. Growth factor, that's the tyrosine kinase transduction pathway. Survival factors, as well as the growth factors, act via the same receptors. Chemokines, hormones, other transmitters like interleukins also interact with their own types of the receptors. Cytokine receptors, additional family, and death factors, that's the FAS receptor, as you remember, the extrinsic pathway of apoptosis. There's different types of signal transduction pathways, and all of them, almost all of them, are targeted to the regulation of the specific genes, which in one way or another are involved into the cell proliferation or activation of certain genes to produce more proteins. So the most important signal transduction pathway for the cell renewal is the tyrosine kinase signal transduction pathway, because it's basically associated with the mechanism of action of different growth factors. You see, there are many of them, plenty of growth factors like epithelial proliferation. For proliferation of these cells, there are some growth factors like these which are responsible for that. For monocyte hemataxis, we see another kind of growth factors. For fibroblast migration and proliferation, we get another families of growth factors. Very important growth factors for angiogenesis, synthesis of collagen, and regulation and remodeling of collagen by the production of collagenesis. So after all, the mechanism of tyrosine kinase signal transduction pathway is depicted in this schematic. You see, that's quite sophisticated process, which got different types of mediator. And finally, this, like the domino effect, is leading to the activation of transcription of certain proteins, certain genes, which are responsible for the cell cycle progression. Important point, tyrosine kinase signal transduction pathway also responsible for the oncogenesis, for the formation of tumors. And why it's important to study this type of signal transduction pathway, because understanding of this mechanism will shed the light on the tumor growth, and why the mutation in the certain genes which are responsible for the receptors or other mediators of the signal transduction pathway may lead to the uncontrolled cell proliferation. And we will discuss about that in appropriate topic. Today, that's the growth factors which are involved in repair. And again, you see the table, you can watch it more carefully after the lecture when we put on the pause this slide, and you will see the distinct functions of certain growth factors. Just an example of VEGF, you see that's the vascular endothelial cell growth factors, which is very important for the formation of so-called granulation tissue. And the source of the VEGF, see, that's the multiple source, mesenchymal cells. Literally all kinds of mesenchymal cells, starting from bone marrow cells, finishing with osteoblasts and endothelial cells, may produce VEGF. What is more important, that this factor is mitogen, the potent mitogen for endothelial cells. And that's clear for us, because finally the stimulation of the proliferation of endothelial cells leads to the formation of new vessels. And you see here, just to remind you, the cell cycle and its impact on the cell renewal. You see there are several steps in the cell cycle. From G0, that's the standby mode of the cell, G1, S phase, G2, and finally M phase, that's the mitosis by itself, and you see the occurring of cellular division. And turning back cycle by cycle depending on the cellular population. Also, there are important checkpoints of the cell cycle. So, and that's the certain protein regulators which can stop or permit the continuous duration of the cell cycle. According to the capacity of the proliferative capacity of tissues, we divide all cellular populations into three types. First, there's the labile tissues. Labile tissues, they got a continuous physiological cell turnover by replacement from stem cells and by proliferation of mature cells. Good examples of that is the hematopoietic cells, like different branches of hematopoiesis, mesenchymal stem cells, surface epithelia, columnar epithelium of the gastrointestinal tract, uterus and fallopian tubes, transitional epithelium of the urinary tract, urothelium. And what is characterizing of this type of tissue, that they can readily regenerate after injury as long as the pool of stem cells is preserved. So that's the cells with the highest level of regenerative capacity. Second population of cells or tissues, that's the stable tissues. Basically, the vast majority of cells in stable tissues, there's the quiescent cells, which means that normally in postnatal period, they are in the G0 stage of the cell cycle. So they are, from the proliferative point of view, they are dormant. But they can be awakened after the injury. So they are capable to proliferate in response to injury, or loss of tissue mass. And that's again the wise regulation of the cellular population, wisdom of the nature. Basically, these cells constitute the parenchyma of most solid tissues like liver, kidney, pancreas, and other glands. Also, they include the most important population of the connective tissue cells like endothelial cells, fibroblasts, and smooth muscle cells. And they are responsible for different adaptation mechanisms like metaplasia, hyperplasia, and hypertrophy. Permanent tissues and permanent cells, that's the last subgroup of the tissues in the proliferative capacity classification. Basically, that's the terminally differentiated and non-proliferative in postnatal life, like cardiomyocytes and neurons. These cells repair is typically dominated by scar formation. Again, why it's not fair, right? From the first, at a glance, because neurons, they are the most important cells in our body. Cardiomyocytes, they are also very important cells. Why they couldn't regenerate, why they couldn't proliferate, but I guess that's pretty clear from the point of view of the functionality. Functionality of the neurons and cardiomyocytes are dependent on the interaction with other cells, and they got billions of connections with different cells. Just imagine if the neuron will need to proliferate, it must abrupt all the connections with other cells, which means loss of functionality. So that's why it's impossible. It's just impossible, and that's why it's arrested from the genetical level. So these cells just cannot proliferate, and that's really wise. You see that most mature tissues and organs contain variable proportions of 3 cell types: labile cells, quiescent cells that can return to the cell cycle, and non-dividing cells. And these proportions finally determine the regenerative capacity of organs. The very important point, that's the stem cells. Stem cells in the labile tissue and stem cells in the embryonic tissues. So you see in the developmental period, in the embryonal period, they give rise to all the various differentiated tissues. However, in adult organism, these cells are replacing damaged cells and maintain tissue populations as individual cells within them undergo replicative senescence due to attrition of telomeres. Remember this Hayflick limit. Basic features of these cells concluded in the self-renewal and asymmetric division. What does it mean, asymmetric division? It means that after the division, one cell is differentiating into the functioning type of cell in this tissue, like epithelial cell. Another one is continue the business of stem cells. The good examples of stem cells, there's the embryonic stem cells and tissue adult stem cells, like hematopoietic stem cells and mesenchymal stem cells. Also, nowadays we have deal with another term, that's so-called induced stem cells. We will discuss about that in the end of the lecture, and that's a very interesting point. You see this beautiful animal, that's the newt, and it's a very good example of a species with perfect limb regenerative capacity, because the limb amputated limb of the newt could be restored in almost 100 days after the complete amputation. How it's possible, and why again it's not so fair, right? Human is not capable for that. I will try to explain you why it's going on, why the newt's limb could be restored and our limb is not. So look, first of all, look at this schematic. We are starting from the normal homeostasis, the balance of proliferation and apoptosis, and then somehow the injury is occurring. What kind of injury? We already discussed about that in the previous topics, and we know how the cells and tissues could respond on that. You know about inflammation. And after all, the inflammation must be resumed into different types of processes. That's healing or regeneration. What is the difference? As I told you, healing, that's sort of substitution. Regeneration, that's the restitution of tissue and cells, and as you may see, it depends, first of all, the capacity of cell and tissue proliferation and the volume of this injurious stimuli. You see that regeneration may occur in renewing tissues, and in stable tissues then the extracellular matrix is conserved. And for sure that kind of regeneration may occur as the compensatory growth of liver and kidney. We will discuss about that a bit later. Healing in its turns is developing in case of the wound formation. Then there is the massive defect of tissue which is necessary will be restored through the formation, at least temporary formation of scar. And chronic inflammation may lead to the diffuse growth of scar tissue. We call it fibrosis. That's schematically demonstrated here. It's like the very common schematic of the tissue, which contains of the epithelium, some subepithelial layer, and some mesenchymal cell in the extracellular matrix. See, after the mild or superficial injury, we see the complete regeneration because there is no involvement and no injury of the stable cells, mesenchymal cells, and there is no activation of the scar formation here. Just simply the proliferation of the epithelium is leading to the complete regeneration or restitution. However, in case of the severe injury and involvement of extracellular matrix, we see the scar formation. The same in case of the fibrosis. That's the fibrosis or cirrhosis of liver. Then we see the extinction in some cases of hepatocytes. For example, after the poisoning with mushrooms or heavy metals, there is the extinction of hepatocytes, but anyway, there is no injury of extracellular matrix. In that case, we can expect the regeneration of the liver tissue. However, in case of the severe damage of extracellular matrix, like we can see that during the alcoholic intoxication, continuous and repetitive injury, there is the high chance of development of the scar tissue and finally development of the cirrhosis. Regeneration. The resuming of this topic is here in this text. So the regeneration of injured cells and tissues involves cell proliferation driven by growth factors. It's critically dependent, first of all, on the integrity of extracellular matrix and by the development of mature cells from stem cells. So these two mandatory criteria: integrity of extracellular matrix and stem cell presence. Then note that tissues again are classified as labile, stable, and permanent. Continuously dividing tissues contain stem cells. They can differentiate to replenish lost cells. Cell proliferation is controlled by the cell cycle, and they could be stimulated by growth factors and interactions of cells with extracellular matrix. And regeneration of the liver is a classic example of repair by regeneration. It's triggered by cytokines and growth factors produced in response to loss of liver mass and inflammation. In different situations, regeneration may occur by proliferation of surviving hepatocytes or a repopulation from progenitor cells. Do you remember the legend of Prometheus? No, not this Prometheus. This one, the Greek one. That's the Greek guy. Okay, in fact, it was the Titan. It was the hero. Here shed the light of the knowledge to the ancient humans, and he shared the secret of knowledge from gods, and for that he was punished by Zeus. And he was punished by binding him to the rock, and every day the eagle came to this rock and eat part of liver of this hero. So anyway, the piece of liver has restored after time, and you see what's going on. So there is the full restoration of liver. Indeed, that's not only the fairy tale, that's the true story. See the example from contemporary times. On the image A, it was the partial hepatectomy that's encircled with the white line, and yeah, that was a donor. It's like the Prometheus for transplantation purpose. Yeah, by the way, don't miss this image, because that's the response to the third question in my questionnaire for registration form. So people, and you see that after the removal of this part of the liver, it was completely, not completely, but almost completely restored, and I mean in the same amount of tissue, and we call it regeneration. That's the compensatory enlargement of left lobe. Anyway, the population of the hepatocytes is the same, so everything is going okay. So then, liver regeneration by proliferation of hepatocytes could be explained by interaction of these cells. You see, the following partial hepatectomy, the liver regenerates by proliferation of surviving cells. The process occurs in stages, including priming, followed by growth factor-induced proliferation. Once the mass of liver is restored, the proliferation is terminated, and this is the self-regulating process. That's once again just to remind you that the community of cells connected with each other like the spiders on the spider web. The next point, that's the repair by scar formation. Scar formation, that's so-called substitution, and tissues are repaired by replacement with connective tissue in this case. Scar formation may occur if the injured tissue is not capable for proliferation, or if the structural framework, the integrity of ECM is damaged and cannot support the regeneration. So it's like the spider web was broken, right? The main components of connective tissue repair are angiogenesis, migration, and proliferation of fibroblasts, collagen synthesis, and connective tissue remodeling. Repair by connective tissue starts with the formation of granulation tissue and culminates in the laying down of fibrous tissue. Multiple growth factors may stimulate the proliferation of the cell types involved in repair. And you see that important point, this tumor growth factor beta, transforming growth factor beta is the potent fibrogenic agent. Extracellular matrix deposition depends on the balance between fibrogenic agent like TGF-beta and the presence of so-called matrix metalloproteinases that digest excess of extracellular matrix, as well as the inhibitors of these metalloproteinases, that's TIMPs. This quite complex and sophisticated regulation finally is realized. People, if you got some interruptions in the live translation, please write me about that. I will repeat some points if you really need that. So don't forget about that. So let's check the connection. Could you hear me now? Hello, people. Just write me some messages. Could you hear me now? Just type me about what did you miss and we will. Okay. Okay, Gary. Thank you. Thank you. So let's continue. Then my question now is, for which discovery Nobel Prize awarded in physiology and medicine in 2019? Huh? Could you answer this question? Who knows that? For which discovery? Okay, you can Google it, but Google that very fast because I want to respond right away. You see, these three guys, William Kellin, Greg Semenza, and Peter Radcliffe, what they discovered 20 years ago, they discovered very important agent for angiogenesis. That's the HIF. See, hypoxia-induced factor. In fact, that's the dimer because it exists in the two sub units, and these subunits are divided normally by different compartments of cell. So HIF alpha is existing in the cytoplasm, and HIF beta we can find in the nucleus. So normally, with the normal presence of oxygen in the condition what we call normoxia, the HIF alpha is blocked, and it just couldn't be connected with HIF beta. So you see, there's like the two brothers which are divided. Yeah, but doesn't matter. You see, in case of the hypoxia, the absence of oxygen leads to the combining of this, uniting of these two molecules, and altogether they are becoming a potent factor for angiogenesis. They are activating the genes which are producing vascular, vascular endothelial growth factor. And here we are, angiogenesis. How to explain this? It's pretty clear why the vessels are trying to reach the less oxygenated point of tissues. That's now pretty clear because of the concentration of HIF and polymerization, dimerization of HIF, which is leading to activation of VEGF production. And hemotaxis finally provide this targeted growth of the sprouting, of the sprouts of the new forming vessels. Just pay attention, that's angiogenesis, not vasculogenesis. Don't be confused. As you remember, vasculogenesis, that's the prenatal formation of vessels, embryonic growth of vessels. If we're talking about the cell repair and regeneration in the postnatal period, that's angiogenesis. Also, VEGF is very important in the tumor growth, and we will discuss about that in appropriate topic. So over here you see the different steps of angiogenesis. First of all, VEGF is responsible for vasodilation, and that's very important because endothelial site, which is on the closest position to the hypoxic area, is becoming a leader. That's the leading cell. Under the influence of VEGF and Notch signals, it's just drilling the pericytes. It's becoming the vessel without basement membrane, you see. And this tip cell finally is probably just drilling the extracellular matrix, producing different enzymes. And the endothelial cells which are following it, this cell, proliferating, creating the new stalks of the vessel, and formation of new vessels is going on. And we see the mesh, the network of new vessels that we call in the wound the granulation tissue. That on this photo you can see the granulation tissue after the 5 days of injury. And unfortunately, this granulation tissue is representing the malfunctioning of the regenerative capacity in the patient with diabetes mellitus. So diabetes mellitus, that's the potent factor which provide the obstacles in the regenerative capacities of the individual. And this is, for comparison, this is the granulation tissue after the same 5 days in the patient after burn without underlying pathology. You see this like the fresh, juicy, red tissue, which consists of many granules. These granules, in fact, is the small loops of the vessels, and that's why it's called granulation tissue. However, sometimes the contamination of wound with germs, with some bacteria, may lead to the overstimulation of proliferating vessels, and it may lead to so-called proud flash. That's the exuberant granulation. So it could be treated quite easy with antibiotics and surgical removal. However, sometimes we can observe these abnormalities of the wound healing. Microscopically, you see it resembles sarcoma Kaposi, a lot of spindle cells which are trying to create the new vessels, however, not successfully. So that's the exuberant granulations microscopically. This is the normal granulation tissue after 5 days with the staining with the trichrome. You see the blue fibers, that's the collagen, and you see a lot of capillary-like vessels. That's the granulation tissue by itself. However, in time, after 1 month, you see the obvious changes, and granulation tissue as a temporary tissue is disappearing and is replacing by scar tissue. So that's the substitution finally is occurring. And again, that's logical. Just to provide the formation of new tissue, we need new vessels, right? So the step with the formation of new vessels, the step of granulation tissue is necessary in wound healing, for sure, and under the certain circumstances. The circumstances of deep and severe hypoxic changes in the tissue. Fibrous tissue formation, that's not the end of the story. You may notice that after the formation of scar, we see the decrease of scar volume. We see decrease of scar volume, and it means the remodeling of the fibrous tissue. Remodeling of fibrous tissue, that's the process of the continuous degradation of the collagen mass, and that's regulating by the macrophages. And you see from this point of view, macrophages, that's not only the cells which are scavenging the microbes, killing the pathogens, the digesting the necrotic debris. That's also the cells which may build and regulate the building of new tissue. In this case, that's the fibrous tissue. And the macrophage is regulating the process of formation of the collagen in this case by stimulation, by the production of growth factors over here. And finally, it leads to the formation of the procollagenesis and prostromelizins. Macrophages can, from one hand, can stimulate the fibroblasts. From another hand, they can produce the enzymes that can digest collagen. That's the matrix metalloproteinases. And the regulation of, just to avoid the excess of matrix proteinases and complete reduction of the scar tissue, they also may produce the TIMPs, the inhibitors of the matrix proteinases, and in such a way we see the overregulation of this process. So that's why, again, it's becoming wise. It's becoming just enough, just sufficient to provide the normal substitution of wounded tissue. And the fibrosis in parenchymal organs, basically it's occurring due to the repeated or severe injury. For example, in case of the chronic infections, in case of the chronic autoimmune diseases, like we may observe, for example, in case of development of chronic liver, chronic hepatitis B, then we see the finally development of liver cirrhosis, or like in case of the chronic inflammatory processes in the lungs. Resuming wound healing. The main phases of cutaneous wound healing are inflammation, formation of granulation tissue, and extracellular matrix remodeling. Cutaneous wounds can heal by primary union, first intention, or secondary union, second intention. Secondary healing involves more extensive scarring and wound contraction. Wound healing can be altered by many conditions, particularly infection and diabetes. The type, volume, and location of the injury are important factors that influence the healing process. Excessive production of extracellular matrix can cause keloids in the skin. You see that what is going on then, there is the reduced function of matrix metalloproteinases. Persistent stimulation of collagen synthesis in chronic inflammatory diseases leads to fibrosis of the tissue, often with extensive loss of the tissue and functional impairment. Just examples of cutaneous wound healing. You see it started from hemostasis, and you see the accumulation of platelets over here, and beginning of the fibroblast migration into the edge of the new wound. Then inflammatory phase. You see hemostasis occurs during hours, inflammatory phase during days, basically 5 up to 7 days. And you see the infiltration by neutrophils, monocytes, which are transformed into macrophages. In this stage, we see the development of wound sterilization, engulfment of dead cells, early reparative responses. Also, we may find the activation, migration of tissue-resident lymphocytes, neutrophil, macrophage, and monocyte recruitment from circulation. And after 1 or 2 weeks, we see the development of proliferative phase, when we see the proliferation of both mesenchymal and epithelial components. It includes reepithelialization, vascularization with formation of granulation tissue, formation of myofibroblasts. They're quite important because they are responsible for wound contraction, and lymphocyte recruitment. And after all, we see the development of the remodeling phase, more than 2 weeks after the collagen deposition, cross-linking, ECM remodeling with the reduction of the collagen mass, formation of the mature scar tissue. You see the differences between the healing by first intention and healing by second intention. In case of the first intention healing, we have dealt with the wound with the regular shape, basically this kind of the knife wound. It could be the wound after the surgical intervention. And in this case, we see the minimal injury of the extracellular matrix, minimal inflammatory response if the injury was performed by sterile surgical tools. And in this case, there is the minimal formation of fibrous tissue, almost invisible scar, so-called fibrous union, And what is really important, the first intention is not conducted by the formation of the granulation tissue. In contrast to that, second intention basically healing basically associated with the large wounds, infected wounds, and in this case and that's necessary, the formation of granulation tissue. And after that we see the formation of large scar. Here you see the dynamics of the wound healing, and you should realize that all the steps, the inflammation, granulation tissue formation, and wound contraction, that's not the steps which are occurring one by one. They are overlapping with each other. And these curves, they are overlapped more or less depending on the predisposal condition of the patient. And just to remind you, these predisposal conditions can be associated with some background diseases like diabetes mellitus, like some other infection, contaminated wounds, some other genetically predisposed conditions which may impair healing of wound. Also, this genetically predisposal condition, which basically associated with the decreased activity of matrix metalloproteinases, may lead to the formation of keloid. See, this is the exceeding collagen masses, and you see this formation of the scars which are inadequate to the injury of the skin. For example, like this, you see the very large scar which is exceeding the size of the wound, previous wound. Don't confuse the keloid with the hypertrophic scar. Sometimes we see the large scars due to the formation of large wounds, but anyway, it's not the same as the keloid. Keloid is basically associated with the genetically predisposal conditions. And again, fibrosis as a result of severe or repetitive injury of the tissue. In the bones, however, we see the very specific scenario of the tissue healing process. There are some similarities, some mutual points with the wound healing. For example, there is the primary or secondary consolidation. Anyway, we have deal with 4 different steps, and the first important step, that's the formation of hematoma. If the reposition of the fragments of fractured bone was successful, we see the formation of the hematoma, which is serving as a temporary matrix for the migrating cells. That's an important point. Hematoma is necessary in this case. You see, in the injured bone, there is no more extracellular matrix, and that's why the immobilization and successful reposition of the fragments are very important, because hematoma may provide the most effective migration of the cells to the site of injury. The second step, that's the formation of fibrous or fibrocartilaginous callus, so-called primary callus, for sure with the formation of the granulation tissue over here. It depends on the size of fracture and the distance between the fragments in the fracture, if it would be fibrous or fibrocartilaginous callus. Logically, the fibrocartilaginous callus will be created in case when the distance between the fragments is more pronounced. Third step, bony callus formation after 3 or 8 weeks. We see the composition and replacement of the defect with the so-called woven bone. That's the irregularly created, the bone tissue is the irregular composition of the fibers. However, is becoming more solid and more effective than the previous type of tissues. And after all, as in case of the scar formation, we see the bone remodeling step. In this case, the combination of activity between the and collaboration between the osteoblasts and osteoclasts will lead to the formation of new effective lamellar bone. It depends on the size of the fracture. It depends on the age of the patient. It may take time up to 2 years. So that's the good example of the bone fracture healing in a young patient. You see, after the reposition of the tibia, after 6 weeks, we see the formation of the bone callus. And this is the microscopic appearance of the bone fracture with almost all steps. And you see, that's like the confirmation that I told you before. All processes, that's not just step by step, one after another. They are overlapped with each other. And over here, we can see necrotized tissue, formation of the fibrous tissue, granulation tissue, and formation of the new bone. However, sometimes the consolidation of bone fracture may go wrong, and in that case, we have to deal with the impaired bone fracture healing. It could be delayed union, non-union, or false joint formation, or pseudoarthrosis. If we're talking about the regeneration of nerve tissue, we have to mention, first of all, the peripheral nerve healing. For example, after the amputation, we may see the formation of so-called traumatic neuroma. That's the pathological repair of the peripheral nerves, and it's associated with so-called phantom pain symptoms. See over here, there's the well circumscribed mass arising from the amputated sciatic nerve. Microscopically, it looks like the hypertrophied perineurium, that's the fibrous tissue, and the chaotically displaced axons and neurites. And since they are compressed by the fibrous tissue surrounding them, it may finally produce the phantom pain. The question is, if the newt is so successful, but it's not so successful in intelligence comparing to a human, how to augment reparative capacity of the human body? Nowadays, we got several approaches to that. First of all, that's the formation of so-called induced stem cells or so-called therapeutic cloning. Both of them theoretically are quite effective, but they raise a lot of moral questions for their application. However, theoretically, these processes may lead to the formation of stem cells which can recreate and regenerate apparently all existent tissues in our body. You see, in case of the induced stem cells, we can take any type of somatic cell of our body and activate or just directly transfer the genes from stem cells. In such a way, we see so-called induced pluripotent stem cells. And from this population of cells, we can create neurons, mesenchymal cells, epithelial cells, and others. In its turn, the therapeutic cloning is associated with the transformation of patient cell to the via the nuclear transfer from enucleated oocyte to the nuclear transfer embryo, and in such a way we see the formation of the new embryo with the new tissues. So that's the most concerning way of regeneration, artificial regeneration. However, now we have a potent tool for the improvement of regenerative capacity. That's the field of investigation, field of research. That's bioengineering, the merging between different sciences, between different fields of our knowledge. And finally, for example, the bioengineers already use so-called tissue printers, and they can apply different cell populations all together and create so-called organoids to reproduce, or just to try to attempt to make some kind of tissues like epithelial tissue, endothelial tissues, and other simple tissues. Another approach in bioengineering, that's the formation of tissue reactors, construction of tissue reactors. And these tissue reactors, the previously engineered on the tissue printer cells, could be faced with the approximate environment of our body. For example, the flow of liquids, like which are simulating the flow of blood, and in such a way they can provide the remodeling or modeling, as you wish, of the new formed artificial tissue to the normal environment in our body. For example, formation of this tracheal implant. Another approach for tissue engineering, that's the formation of a brain-computer interface, because sometimes, you know, we just can't improve the impaired function of the brain, impaired function of the central nervous system in this woman, for example, with paralysis of the spinal cord. So in this case, just impossible to have the success because we have deal with very complex tissue as the central nervous system. So for that reason, for example, these investigators use the invasive cortical brain-computer interface with many electrodes, and this brain-computer interface can reproduce the signals from brain to this robotic manipulator. So, and finally, this woman literally can directly manipulate the movement of this artificial arm, and it's, for me, that's awesome. That's so fantastic. I mean, in terms of the future prospects. So I guess it was useful information for you, and thank you very much for your attention. Don't forget to use our Google form for registration, and I hope to see you back in our classes. Thank you so much for your attention again, and have a nice week. Bye bye.